You swallowed a pill this morning, and it took you about 8 seconds, and you did not think about it once. Same glass, same corner of the counter, and same 8 seconds you have repeated every morning for years. And if that pill was amlodipine or Losartan or Lisinopril, I need you to do something right now, before we go any further. Press your thumb hard into the front of your ankle, just above the bone, and hold it there while I count to 5. Now, take your thumb away and look down at what you left behind. If a dent is still sitting there in your skin, like a footprint in wet sand, that is not old age, and that is not too much salt, and that is not from standing on your feet too long. That is your medication speaking to you in the only language it has. And there are 7 things about these 3 pills that a 12-minute appointment almost never has room to explain. The 7th one is not about the pill at all. It is about the hour you take it. Stay with me all the way to the end of this, because that 7th thing is the one that changes the most for the fewest people, and it is the one almost nobody ever hears. My name is Dr. James Weatherly, and everything I do here is built around one simple idea. Adults over 60 deserve clear, honest, plain language explanations about what is actually happening inside their own body. Not scare stories, not sales pitches, just the conversation a rushed appointment never has time for. That is the whole mission, and it is why you are here. Here is the reframe I want you to carry through this entire video, because everything else rests on it. A side effect is not a malfunction. A side effect is a message. Your body is not breaking down when your ankle swells or your throat starts to tickle. Your body is doing exactly what the chemistry told it to do, and then it is reporting back to you honestly about the result. Think about the check engine light on your dashboard. That little light is not the problem. It has never once been the problem. It is a messenger carrying a note, and the note says something upstream needs your attention. What most people do when they see that light is either panic or ignore it, and both of those responses are wrong. The right response is to read the note. That is what we are doing today. We are going to read the notes your blood pressure medication has been sending you, and you are going to walk away understanding your own body better than you did 10 minutes ago. Why has nobody sat you down and explained this properly? There is no villain here, and I want to be very careful about that. Your doctor is not hiding anything from you. What happens is far more ordinary, and honestly far more human than that. A physician gets somewhere between 10 and 15 minutes with you. In those minutes, they have to review your chart, check your numbers, listen to your heart, ask about anything new, address whatever you came in for, and write the prescription. Explaining the full mechanism of how a calcium channel blocker changes the behavior of the smooth muscle in your arteries would take 20 minutes on its own. It simply does not fit. So the explanation gets compressed down to take this once a day and come back in 3 months. And then the symptoms that show up later get blamed on something else entirely because nobody drew the line between them. That is not negligence. That is a system running out of clock. And that gap is exactly where this channel lives. Let me tell you about Walter. Walter is 71 years old, a retired postal carrier from Toledo, Ohio. A man who walked 8 miles a day for 34 years and was quietly proud of the fact that he had never once called in sick. Walter came to me because of his throat, not his heart, not his blood pressure. His throat. He had developed a cough, not a chest cough, not a wet, productive cough that brought something up and gave him relief. It was a dry, scratchy tickle that sat right at the top of his windpipe and simply would not lift. He cleared his throat before he spoke. He cleared it in the car. He cleared it in the middle of sentences at the dinner table, and his wife had stopped noticing because he had been doing it for the better part of 9 months. It woke him at night. It was worse when he lay flat. It was worse in the cold air. And Walter, being a practical man who solved problems, had done what practical men do. He had gone hunting for the cause. He replaced the furnace filter. Then he replaced the furnace filter again with a more expensive one. He bought a humidifier. He bought a second humidifier for the bedroom. He tore up the carpet in the den because he decided it was holding dust. He gave away the cat. Think about that for a moment. This man gave away a cat he had for 6 years because he was so certain the answer was an allergy. He was tested for allergies and everything came back essentially unremarkable. He was put on an inhaler for suspected asthma and it did nothing at all. He was told it was probably reflux and given a stomach acid medication, and he took that faithfully for 4 months, and the cough did not budge a single inch. By the time he sat down in front of me, he was tired, and he was frustrated, and he said something I have heard many times in slightly different words. He said, "I think I am just getting old, and this is what old sounds like." When I asked Walter what medications he was taking, he listed them without a second thought. And there it was, sitting in the middle of the list, completely invisible to him. Lisinopril. Started a little under a year ago. Walter had been swallowing the cause of his cough every single morning for 9 months, and he had never once suspected it, because the cough did not start on day 1. That is the part that fools people. That is the trap. Here is what almost nobody realizes about lisinopril. Lisinopril belongs to a family called ACE inhibitors. Let me unpack that in plain language. Your body makes a substance whose entire job is to squeeze your blood vessels tighter and tell your kidneys to hold on to extra fluid. Tighter pipes and more fluid inside them means higher pressure. To manufacture that squeezing signal, your body needs a specific enzyme, and ACE is simply the name of that enzyme. Lisinopril blocks it. Picture a factory that produces the tightening signal, and lisinopril walks in and shuts the factory floor down. No factory, no signal, vessels relax, pressure comes down. It is an elegant and genuinely excellent medication, and it has protected an enormous number of hearts and kidneys, and I want to be crystal clear that I am not here to talk you out of it. But that enzyme has a second job that nobody mentions. It also breaks down a substance called bradykinin. Bradykinin is an irritant. Your body produces it and then quietly disposes of it, and you never notice a thing. When you block the enzyme, you block the disposal crew too. Bradykinin starts to accumulate in the tissues of your airway and your throat, and it irritates the nerve endings there. Those nerve endings interpret irritation as something is stuck in here, get it out, and they trigger the cough reflex. Except nothing is stuck. There is nothing to bring up. So you cough and clear and cough and clear, and you get no relief because there was never anything there to begin with. Think of it like a smoke detector with a sensor that has become too sensitive. There is no fire. There is no smoke. But the sensor is now reacting to steam from the kettle, and it will not stop shrieking. Or picture a drain in your sink. Water flows in and water flows out, and the level stays perfectly fine. Then someone puts a plug halfway down. Nothing dramatic happens immediately. The level just rises slowly, over weeks, until one day it spills over the edge. That is bradykinin. That is why the cough can appear months after you started the medication, and that delay is precisely why nobody makes the connection. Research has consistently found that this cough affects a meaningful minority of people taking ACE inhibitors, and it is well documented enough that it is one of the single most common reasons a physician will switch a patient to a different class of medication entirely. It is not rare. It is not exotic. It is one of the most predictable things in all of blood pressure medicine, and yet Walter gave away a cat. If you have been clearing your throat for months and you take lisinopril, type the word throat in the comments right now. I want you to see how many other people are sitting there with exactly the same story and exactly the same furnace filter. Now here is the part I need you to take seriously, because a dry cough is annoying, but it is not dangerous. There is one thing on this list that is. In rare cases, ACE inhibitors can cause a reaction called angioedema, which is sudden swelling of the lips or the tongue or the face or the throat. If you ever notice swelling in those places, especially if it is becoming harder to swallow or harder to breathe, that is not a wait and see. That is emergency care immediately. That reaction can progress within minutes. Dry cough. Mention it at your next appointment. Swelling of the lip or tongue or throat. You go now. I need you to hold on to that difference. But the cough was only the first thread, and Walter's story does not end there. Before we go further, I want you to remember what your thumb did to your ankle at the start of this video, because the second thing on this list is about that dent. Amlodipine works through a completely different door. Your arteries are wrapped in a layer of smooth muscle, and that muscle tightens when calcium flows into its cells. More calcium in, more squeeze, higher pressure. Amlodipine narrows the gates that calcium uses to get in. Fewer gates, less calcium, less squeeze, lower pressure. Simple and effective. But here is the wrinkle almost nobody explains. Amlodipine relaxes the small arteries carrying blood down into your legs far more effectively than it relaxes the small veins carrying blood back up. The road in gets wider. The road out stays the same width. Blood arrives at your ankles easily, and then it sits there in a traffic jam, and the fluid pressure pushes a little liquid out into the surrounding tissue. That is your dent. That is why your shoes fit fine at 7 in the morning and feel like a vice by 6 in the evening. That is why the swelling is gone again when you wake up, because you spent the night lying flat and gravity finally stopped working against you. It is not your heart failing. It is not your kidneys shutting down. It is a completely predictable mechanical consequence of what this medication does to the plumbing in your lower legs, and it terrifies people who do not know that. What makes this genuinely dangerous is not the swelling. It is what people do about the swelling. They get embarrassed. They stop wearing the shoes they like. They stop going out. And then, quietly, without telling anybody, they start skipping doses on the days they want their ankles to look normal. Their blood pressure climbs in complete silence for weeks, and blood pressure gives you no warning at all when it climbs. Please hear me on this. Skipping a dose to control the appearance of your ankle is trading a cosmetic problem for a stroke risk, and it is one of the worst trades available to you. If your ankles are swelling, that is a conversation with your doctor, not a decision you make alone at the counter. We are about halfway through, and I want to remind you where we are going. You now understand the cough, and you understand the dent. The third piece is the one that lives in your kitchen and not in your medicine cabinet at all. And after that, we arrive at the seventh thing, the one about timing, which is the reason I asked you to stay to the end. Losartan belongs to a family called ARBs, and it works on the very same system as Lisinopril, but from a smarter angle. Lisinopril shuts the factory that makes the tightening signal. Losartan lets the factory run at full speed, but locks every door the signal needs to enter. The message gets sent, and the message never gets received. And because the enzyme is left alone, bradykinin still gets cleared away normally, which is exactly why Losartan does not typically cause that cough. That is the whole reason your doctor may one day suggest a switch. Not because one pill is stronger, because one of them stops you coughing at 2 in the morning. But both Lisinopril and Losartan share a quieter consequence, and this one hides in plain sight. Both of them cause your body to hold on to more potassium. In most people, that is completely fine, and it never becomes an issue. In some people, particularly seniors, and particularly anyone whose kidneys are not quite as efficient as they once were, potassium can climb higher than it should. And potassium is not a casual mineral. Potassium controls the electrical rhythm of your heart. When it drifts too high, the electrical timing of every beat starts to distort, and the warning signs are frustratingly quiet. A little muscle weakness, some cramping, a heartbeat that feels like it stumbled, sometimes nothing at all. Now walk into your kitchen in your mind. Look at the salt substitute on the counter, the one with "Heart Healthy" written across the front in a friendly color. Turn it over. In a great many of those products, the sodium has been swapped out for potassium chloride. Look at the electrolyte powder you stir into water after a warm afternoon. Look at the nutritional shake you drink because someone told you seniors need more protein. Every one of those is quietly adding potassium to a body whose medication is already instructed to keep more of it. Nobody is being careless. Everybody in that scenario is trying to do the right thing. The gap is not in your discipline. It is in the information you were given. Walter had a salt substitute on his counter. Of course he did. He was a careful man doing what he believed was the healthy thing. And there is one more thing hiding in a different room of the house. Go look in your bathroom cabinet later today and find the ibuprofen or the naproxen, because almost everyone has one of them. If you take Lisinopril or Losartan, especially alongside a water pill, regular ongoing use of those pain relievers can reduce blood flow through your kidneys and put real strain on them. Not because any one of those three things is dangerous on its own, because together, in a body that is even slightly dehydrated, they create conditions your kidneys genuinely struggle with. And nobody ever mentions ibuprofen at an appointment because it came off a supermarket shelf and it does not feel like real medicine. It is. Ask your pharmacist directly. Is it safe for me to use ibuprofen regularly given everything I am taking? That question is free and it takes 90 seconds. I also want to prepare you for the day you get sick, because it will come. If you catch a stomach virus and you are vomiting or you have diarrhea or you simply cannot keep fluids down, your body is now a completely different environment than it was yesterday. These medications assume a normal fluid balance. When that balance is stripped away, the exact same dose that served you beautifully for years can now push your blood pressure too low and stress your kidneys. The medication did not change. You changed. Write this down and stick it somewhere you will actually find it. If I cannot keep fluids down, I call my doctor before I take my blood pressure pill. Which brings me to the seventh thing. the one I promised you at the very beginning and the reason I asked you to stay. Your blood pressure is not a fixed number. It never has been. It follows a daily rhythm, the same way your body temperature does and the same way your sleep does. It typically drops during the night while you sleep, and then it climbs in a surge in the early hours of the morning as your body prepares itself to wake and stand and move. That morning surge is real, it is measurable, and researchers have long recognized it as the window in which cardiovascular events cluster most tightly. Most heart attacks and strokes do not strike at random. They happen disproportionately in those early morning hours. Now think about when almost everybody takes their blood pressure medication. Morning. With breakfast. Because that is when we remember. Here is the question that hardly anyone asks. Is a pill you swallowed at 8 in the morning still working at full strength when that surge arrives at 5 the following morning? For some medications and some people, the honest answer is yes. For others, it is a much softer yes than anyone assumed. This is a real and active question in medicine, and I want to be completely honest with you that the research has gone back and forth on evening dosing, and there is no single universal answer that applies to every person and every pill, but that is exactly the point. It is a real question, and it is a question that fits your specific medication and your specific body, and it is a conversation almost nobody has ever had with the person who wrote their prescription. The hour is not a detail. The hour is a lever, and it is a lever that costs nothing at all to consider. None of that means you go home and move your pill tonight. That is not the message, and I want no misunderstanding about it. It means you bring the question to your doctor and let them answer it for you specifically because they know your kidneys and your history and your other medications, and I do not. Let me finish Walter's story. Walter went back to his doctor with one clear question, and it was not about his throat. It was about his pill. He asked whether the Lisinopril could be causing the cough. His doctor moved him onto a different class of medication, and Walter went home not expecting very much because he had stopped expecting things. Around 3 weeks later, he told me, he was in the car, and he suddenly realized he had driven the whole way to the store without clearing his throat once. Not once. He said he sat in the parking lot for a full minute, just noticing the silence in his own chest. 9 months of nights, 2 humidifiers, a carpet, a cat, and the answer had been in his hand every single morning for 8 seconds at a time. He also took the salt substitute off his counter after his potassium was checked, and he asked his doctor about the timing of his dose, and they had a real conversation about it, and that was the first time in his life a doctor had ever discussed the clock with him. So here is what I want you to actually do this week, and I want to be very plain that this video is about understanding, not about changing anything on your own. First, write down every symptom you have quietly written off as just getting older since you started your medication. The swollen ankle, the throat, the dizziness when you stand. Write the date you started the pill next to it, because the timeline is the clue, and delay is what hides these things. Second, walk into your kitchen and turn over every product that says heart healthy on the front, and check whether the sodium was replaced with potassium, because your medication is already holding on to more of it. Third, look in your bathroom cabinet and be honest with yourself about how often you actually take ibuprofen, and then ask your pharmacist whether that is safe for you, because that is the question nobody thinks is worth asking. Fourth, start measuring your blood pressure the same way every time. Same arm, same chair, same hour. After 5 quiet minutes of sitting still, because a single frightened reading taken in a panic is noise, and only a pattern is information, and only information deserves a decision. And fifth, take the timing question to your doctor and ask it out loud. Ask whether the hour you take your pill is the right hour for you. Never move it yourself, and never stop or change a dose on your own, because stopping a blood pressure medication suddenly can be genuinely dangerous. But ask the question because you will very likely be the first patient that week who did. Everything I have told you today is for your understanding, not your diagnosis, and your own situation belongs in a conversation with your own doctor who knows the whole picture. Here is what I hope you take away from Walter. He did not need a stronger medication. He did not need a specialist. He needed one conversation, and nobody had ever told him it was available to him. The most powerful thing you own in that examination room is not fear, and it is not compliance. It is a good question, asked out loud. If you found this useful, share it. And I want to be specific about who to share it with. The person who most needs this is almost certainly not searching for it. They are sitting quietly with a cough they blame on the weather, or an ankle they are embarrassed about, and they are not going to type any of this into a search bar because they have already decided it is just age. That person is your husband or your sister or the man 2 doors down. You might be the entire reason they finally ask the question. Subscribe so this finds you every week, because next week I want to talk about the reading you take at home and why the number on that little screen can be off by a startling margin for one reason that has nothing to do with the machine and everything to do with the chair you are sitting in. I'm Dr. James Weatherly. Take good care of yourself this week.